Welcome to the HIVE Nurse podcast, where nurses, leaders, and change makers come together to connect, learn, and transform healthcare. I'm Ashley Kellish and very excited to be here with you today.
Yep, and I'm Elizabeth Walters. Let's get into it. What are we talking about today, Ashley?
Well, we're talking about something that is not my favorite subject, but I think it's important that I tell you something. I'm going to share you a little secret. Do you know that I hate Halloween?
I did not know that.
Yes, I have. First of all, I hate scary things. Right?
Cool.
You would be surprised to think that of all the things that I celebrate. I do not like this holiday that we are celebrating this month for a variety of reasons, mainly because in the New England winters, I was stuck wearing turtlenecks and parkers over my costumes, running around in the freezing cold rain, and getting scared was just not my thing. So this episode, I'd like to transfer that hate of Halloween and hate of scary things to talk about some other scary things that we see here in our healthcare setting.
Well, I'm going to interrupt and tell you how much I love Halloween.
Of course you do. That is so on par.
I love all the ghost stories, the ghouls, the costumes. I don't know if any of our listeners know that I love to sew, and so I usually make my kids' costumes every year.
Of course you do. And they're probably perfect. Not a thread out of place. Do you like Wednesday Addams?
I do. That's like my favorite show.
Yeah.
Yep. I love the Addams Family, so for sure. Yep. So what are we going to talk about today about scariness in healthcare?
Well, I think it's important that we take some time to recognize that in today's environment that we are caring for patients and working hard, it is still such a challenge to not create situations that are scary, not only for ourselves, but for our patients. And I think that some of the statistics we're going to talk about today, I have been hearing for the past 10 years. And that's what makes it scary to me, because I feel like we are not moving the needle when it comes to errors and mistakes and issues that we have in our healthcare environment today.
We have not moved the needle at all. So we're going to get into some of our facts, right? So our nerdy nurses here.
Yes.
One really interesting fact that I think all of us have been hearing for a long time is that medical errors or errors in healthcare are equivalent to 2 jumbo jets crashing every single day. So could you imagine if 2 jumbo jets were crashing in the air every single day? They'd shut the FAA down. They'd shut down airspaces, all the things. But in healthcare, there's that many mistakes, 360 daily, that are that cause errors that are life-threatening, scary things.
Well, and I think what's so scary about it is that, first of all, like we've said, I've heard that statistic since I was teaching simulation 10 years ago. That's what we used to tell the people that we worked with. So that has not changed despite all the emphasis on quality and safety and all the layers of leadership that we've built in to protect ourselves in healthcare settings. It's not done it. And because it's happening every day. And you know, what about the ones that we don't even see, right? I mean, this is just the ones that get documented.
For sure. And the WHO, the World Health Organization, tells us that every day 1 in 10 patients is harmed while receiving healthcare globally, with more than 3 million deaths annually across the world.
You know, it's interesting. I just had a close friend and colleague who had to bring her son to the hospital. He's an athlete, 18 years old, tip-top shape, actually being scouted by different basketball colleges, you know how that part works.
Yes.
So very important. And he went for his sports physical and they found an error on his EKG. They found something off. So they sent him in. Do you know it took them 4 days to diagnose him with acute pericarditis? 4 days.
Oh my goodness.
18-year-old sitting in a hospital, monitored with chest pain. And it wasn't because they didn't want to do it. It was a delay in reading the cardiac MRI. 4 days of a delay. And this mom that I'm friends with is somebody who is not going to rock the boat. She's not, she's going to do whatever they say. She doesn't want to cause any disruption to it. But when you think about that, that's an error. That's an error right there.
It is. It's an error. It's a delay in care, which is an error, right? So because there aren't enough radiologists reading the cardiac MRIs with the expertise, the patient is not getting the care that they need, and we're having a delay in care for their pericarditis, which should be treated appropriately, right? So
Right.
yeah, that's
Right.
definitely scary. Some other facts that are pretty scary. The Joint Commission releases a report every year on sentinel events, which are those serious safety events. And in 2024, the number of sentinel events rose 12%, with
Wow.
falls, which is nursing, we get
Yes,
marked
we
on
protect
nursing,
from falls.
falls leading the list. But the other things that are on the list are wrong site surgeries, retained foreign objects, and treatment delays. So all of those really serious things that can happen from having those errors happen.
It's really amazing. And when we start to think about why it happens, I think back to teaching some of the DNP students, the Doctorate of Nursing Practice students that we've worked with over the last several years in their graduate program. And I used to pull a set of scenarios from the early 2000s off of this website called Global Nursing and Simulation in Healthcare. And I would play these videos and they would be errors just like you're talking about. Wrong site surgery. There's one, and they're real cases. One was a woman who never received anesthesia. She just received a paralytic. So she basically felt her entire surgery, but she couldn't move during it. Yes. I mean, awful things. And every time I share these with the students, they say, yeah, but this was from 20 years ago, Dr. Kellish. This isn't today. And yet we still can find some of these relatable things that are happening today. And it just makes us think, why? None of us walk into the hospital every day wanting to harm people. That's not what we signed up for. We go in to help, to assist. Even our leaders, they go in thinking that they are there to lead. But there's something about the way that we have developed and allowed broken systems, a lack of organized and fully complemented training, competency training, whatever it is, and these toxic cultures to rise up that we are still seeing these numbers. And those sentinel events should be on the decrease. We should be getting near misses so we avoid those, not on the
Mm-hmm.
rise.
Yeah, for sure. When I was a newly assistant nurse manager, one of my jobs was counseling people on their medication errors, which
Yes.
felt so punitive, right? And it's really, we should be looking at it from a systems perspective. Where are these errors happening? How is the system set up to fail? I'm just going to talk about one of my first medication errors, which of course I was devastated when I did this, but I had been a NICU nurse for many years and everything, I'd never had any that I know of medication errors or anything like that. When I moved into a different environment where medications were not always pre-dosed from the
Right.
pharmacy,
Right.
I accidentally gave a patient a full tablet when they were supposed to receive a half of a tablet. And this was something that, you know, I was so used to getting the pre-dosed medication from the pharmacy that I was making assumptions that whatever came from the pharmacy is what I'm supposed to give the patient, right?
Right.
And so, think about it if they would have cut those tablets in half and sent the actual dose that the patient's supposed to receive directly to the Pyxis so that I could give the correct dose automatically and not have
Yes.
to think, oh, I should be looking for sure to see if this is half a tablet or a full tablet, right? So
I
that
bet you
was
do
one.
every time now, though.
Oh,
I
I
bet you're
don't
oh,
even
yes.
mess around with it. Yeah, I'm looking for pill cutters and the smashers and all the things in the unit when I'm precepting students. But it is not a mistake I've ever made again. But it was just something that we get used to ourselves and our systems that we're running, and then we just make mistakes.
And our systems, too, are built to react so quickly and to put out that fire. I talk about this all the time with teams that I'm working with in coaching. We look at the problem at hand in that one moment, in that one instance, and we will try and fix that. And we will recreate entire systems again that are not sustainable and don't work just to fix that one thing. Meanwhile, the baby's still getting thrown in the river down the way, right? Isn't that saying that you got to look down downstream to see where all the babies are coming from. You can't just collect them one at a time. And we rarely design systems that are sustainable or that prevent this kind of thing. You think about that pharmacy setup. If they're going to do that for that entire one unit, they should do it for all the units, one way or the other. And of course, I'm not a pharmacist and not going to do that. But if not, then there should be something that alerts you to this is a different process, Elizabeth. You have to do something different, because assumptions are what get us every time.
Assumptions get us every time. That's for sure. So when we think about why are mistakes happening, we certainly want to think about not just the system errors, but also the ability to report them and to feel comfortable in reporting them, especially those near misses, right? And so that we can look at the systems errors. So one of the issues that, of course, we see a lot is that there's not psychological safety in our teams in order to report those errors. And so when I was that new assistant nurse manager, that call into my office felt so punitive, where it was like, it shouldn't be a punitive thing. It's not what did you do? It's like, how do we fix the system that's broken here?
I've been reading this book called Drift into Failure, and I think the man's last name is Decker, Dekker. And it's a very hard book. In fact, even for me, I have to read the paragraphs over and over again to get it right. But it's so interesting. And it talks about just that when we create these cultures and the environments where we blame the person, then we're never looking at the whole picture. And then we drift into failure because we become confident and comfortable with status quo and that it's just a people problem instead of looking at the entire system. And I think too, to our training environment as well, all the work that I do with onboarding and orientation, we've been so pushed in our industry to do it quick, bring them on quickly, get them ready quickly. But are we really assessing people for their knowledge, their competency, which is a combination of your knowledge, skills, and attitudes in practice? So it's all of it. Are we truly assessing them? I remember when I started, I had to take a test, the basic knowledge assessment tool, the BCAT. I had to take that test before and after before I started, and then after, to make sure that I had made it to a certain point from a knowledge perspective. Meanwhile, I was being assessed by, and I told you I had an excellent new graduate experience. And so I'm always trying to recreate that environment where I was assessed constantly to see every time I entered a room, did I navigate that patient care effectively? And we've just lost that. We take our educators away from the budgets. Those are the first things to get cut. We take training time away. We're told to do everything with less. I'm ranting and raving about this, but I just think this is a huge part of it. If we were in the financial world, if we worked on Wall Street and you walked in and said, no, I don't really know how to do the stock market stuff. No, I don't really know how to do Excel. I can't really do that. You wouldn't be able to do the job. You would either have to get trained or go find a different job. Meanwhile, we don't have any set processes that really help us assure that even one way of being competent is there. You know what I mean? It's different everywhere you go.
Yeah, for sure. And think about that 12% rise in sentinel events, right? If we were working on the stock market, if there was an increase in stock market crashes by 12% annually, there would be heads rolling on Wall Street.
There would be riots. Yes, there would be things done to do that. But because we can't see it, because all of these things happen in a way that sometimes, like we said, we don't even know if they're being reported. In fact, kudos to all the nurses out there that are willing to put those reports in. I was working with a team just this week, and I asked them how they knew they had psychological safety on their teams. There were some new managers I was working with, and they said, because they come to us and they tell us issues. And I said, do they come to you and tell you when they have made a mistake? And there was silence. And they said, you know what? I don't think I've ever offered that as something they could come to me with. And so we talked about how the true essence of psychological safety is when you come up and say, hey, Elizabeth, you know what? I just almost messed up. I didn't, but I almost did. And let me tell you why, and let's see if we can fix it. And if we could start changing the conversations to that, instead of writing reports up to get people or having the punitive conversations or losing their job over errors that are really system-based, I think we might start to see a difference in our cultures.
Or how about being accused of murder for making a mistake? right? Like when
Yes.
we think about what happened in Tennessee with the nurse who accidentally gave vecuronium instead of Versed for a sedation procedure, and the patient unfortunately passed away. And she reported it. She said, "These are all the things that I did. I overrode the system. We had multiple issues with the systems at the time, and there was major systems errors." And then she ended up being charged with manslaughter, I believe.
Yes. Yes,
And
I think she
and
was too.
her nursing license was revoked. And if they're going to if they're going to make making mistakes punitive like that, no one's ever going to report, right? What's the take home lesson from that? It's like, cover it up, right? This patient just died of natural causes. They didn't die because I accidentally gave them a paralytic instead of a sedative.
Yeah, and that's what's so scary about this. And when that case was being publicized, we were teaching in the academic setting, and it was very widely put out there that this is going to change the way we report in nursing. This is going to affect our culture 100%. And it has. I do think it has, because I think it's a case study now across the country, probably in many different schools and organizations. And hopefully we can learn how to effectively function as leaders in our systems to move away from that. But we've got to band together. And it's, how do we fix this? I think we have to. It's a multi-pronged approach. It's not going to be fixed with even one of these things that we've talked about: psychological safety, training, systems. It's looking at every day as an opportunity to say, is my system functioning well today? Is my care going to be done safely today? Every instance, every time, every day, and building a culture that's ready for that way of thinking.
Absolutely. And I think one of the things we also, we talk about nursing a lot because we're nurses, but we have to also have to think about those interprofessional teams, right? And the psychological safety in those teams. I think we've talked about this in other avenues before, about how it's different going to your nurse manager who is psychologically safe and to say, like, hey, I messed up. It's totally different to go to a cardiac surgeon who might have a little bit of a temper and say, hey, I messed up, right?
Yes.
And the fear that's associated with that. And so I think it's important that we're really investing in teams, not just our nursing teams, but our interprofessional teams, and ensuring that everyone understands what everyone is doing and that we're creating that psychological safety amongst the entire healthcare workforce.
Yes. Yes. And I know sometimes it sounds like we're in our ivory tower telling everybody, what to do. But I think at the end of the day, if you are at the bedside, you can own your locus of control. So you can set yourself up to be safe that day and check on your own personal systems. And if you are in a leadership position, then you can look at your microsystem of, where are my interprofessional teams? Where do I have to build those relationships? Where do I have to look at policies and procedures that we have and actually make them usable? If it's a 78-page central line care document, no one's going to
Yes.
follow that. It's like the
No.
12-step diaper change at the first daycare that my daughter went to. It's not possible. So
Right.
making them make sense, and then investing in our support staff, like our educators, our clinical nurse specialists, all of these people that have the eyes and the expertise to really monitor this practice in this care. I mean, I think it's a multi-pronged approach, but it takes one. For me, I just break it down to one shift at a time. What can we do this shift to create this safe environment? And then that's how you start to build those habits that will continue throughout the rest of your time at that organization.
Absolutely. I can think of examples from my own practice as a nurse practitioner. We often have a interdisciplinary huddle sort of in the middle of the clinic day. So we have 2 clinic sessions every day. And it's where the integrative behavioral health clinician, myself, and the dietitian can sort of come together and talk about the patients we saw in the morning and who we're going to be seeing in the afternoon, just so that we're able to really have that pointed time to talk about what did I miss as the provider? What did the dietitian pick up on? What did the integrative behavioral health pick up on? This often happens where, I'm not picking up on something really nuanced, passive suicidality, and the integrated behavioral health clinician is able to do that, and then I'm able to help get the ball rolling for the safety plan, et cetera. So it is really, really important that we're having those like connection points so that we're able to get all on the same page and we feel safe talking about those things.
What a great strategy, and so simple that anyone can implement that strategy. Even if you're at the bedside, you can say to the physical therapist or the respiratory therapist or that resident or fellow that you're working with, hey, can we have a touch point at 12 o'clock? I just want to make sure I'm following the plan of care. And if anything changes, I'll let you know in between. It's funny, I actually implemented huddles for my doctorate of nursing practice quality improvement project. And at the time, I felt like, oh, geez, is this enough? It's more than enough. And that huddle mentality, not only in sports, but in life, it can really save things.
It really can. It really can.
All right, Elizabeth. Well, let's kind of bring it home. What are a couple of takeaways that we want to take from today?
I think one of the biggest takeaways is the real horror or the real scary part isn't the mistake. It's what happens after the mistake, right? Is it silence? That's the scary part, is that people are making mistakes. We know about that. We know that, and they're being quiet about it. And I think that we're not in an excellent place right now because of things like the nurse in Tennessee who was charged with, manslaughter for making a medical error. I think that scares people. It scares me as a nurse practitioner. I'm much more cautious about the way that I document things, the way that I talk to my teams, the way that I loop people in that I might not have done, 5-10 years ago. I'm much more cautious about sort of the CYA part of medicine. And that's a little bit sad, It's a little bit sad. It's pretty scary.
I think so too. And because I hate Halloween and I don't want to think about scary things when I'm at work doing our jobs and trying our best, because again, we don't walk in to harm someone. I think it's important for all of us to recognize that it's not about perfection. It's about prevention, building cultures and systems that make it easy to do the right thing. That's our goal. And if you can do that one tiny huddle at a time, you're moving the needle, you're moving work forward. So I would say this week, this month, go ahead and look into where you work. Ask something that you've been afraid to ask. Look at one policy and then go to the bedside, especially if you're in leadership or if you're in practice as well. Is this policy actually what I'm doing? And if it's not, fix it. Fix the policy or fix what you're doing. But I think if we take those small steps, we will take the scare out of healthcare and we will make it so that it's not Halloween every time we're going to work.
Yeah. Although I do love Halloween. So,
I mean, you can sit in your bed rotting and watch your Wednesday.
My Wednesday Addams, yes.
And you know what? I'm not going to lie because I've been watching it too, and I'm a little bit obsessed with it, even though it's so out of character for me. But anyways, we want to thank you.
Now we just need to get her onto Stranger Things team.
Oh, gosh. I don't know. One scary thing at a time is enough for me. I mean, I have to go to work, so that's enough. But listen, thank you all so much for listening in to Hive Nurse, where we're trying to transform healthcare using real stories, real situations, and nerdy data to help us connect the work and to make healthcare a better place.
Yeah. And please follow us on all the things. We have YouTube, Instagram. And just remember, you can get CE for listening to this podcast and reflecting on it on hivenurse.com. Join and get your CE hours, which just for listening, which is pretty cool. Happy Halloween, everyone.
It would be scary if you didn't. Happy Halloween,
really,
everyone.
really scary.
All right. Talk to you soon.
Bye.